Welcome to my series of short lectures in clinical surgery. Today's topic is acute cholecystitis, which is most commonly or almost always due to gallstone disease. This is a very important condition as it is very frequent and is one of the most important surgical problems we see in the ward. What is acute cholecystitis? Acute cholecystitis is the acute inflammation of the gallbladder that develops within hours and usually or most commonly due to a gallstone obstructing the cystic duct. Okay, this is the gallbladder with the cystic duct here. So it contains gallstones, and these gallstones blocks the cystic duct. As a result, the gallbladder becomes acutely inflamed, and that is acute cholecystitis. Acute cholecystitis mostly associated with gallstones. In fact, almost always is due to gallstones, 90%. And in 90% or 95% of gallstones in such cases are found impacted in the Hartmann's pouch or the cystic duct. Okay, see the gallstone here, a gallbladder here, and the stone is impacted in the Hartmann's pouch here. Okay, or the cystic duct. There are three types of gallstones: cholesterol stones, pigment stones, and mixed stones. Whereby the most common is mixed stones, a mixture of cholesterol and bile pigment stones. Okay, now we come to the ethogenesis of acute cholecystitis. This can be described in 5 stages from 1 until 5. So what happens is the first stage is the gallstone gets impacted in the Hartmann's pouch of the cystic duct, and this is followed by obstruction and erosion of the lining of the gallbladder. With this obstruction, the second phase comes in. There is increased intraluminal pressure, and this intraluminal pressure increase causes a distension of the gallbladder. Okay, at this stage, the patient feels pain, and typically the pain is visceral in origin and is vaguely located, ill-defined, with nausea, vomiting. There's not much guarding, and the Murphy's is usually negative, and these are the features of biliary colic. And at this stage, if the stone continues to remain obstructed, then the inflammatory process continues on with edema. Okay, the wall becomes edematous and ischemic, and at this stage the patient feels increased pain, and this pain is of somatic origin, which is localized with severe tenderness and guarding with Murphy's positive, and these are all features of acute cholecystitis, which is due to the acute inflammation of the gallbladder. In summary, the pathophysiology, the cystic duct and the neck of the gallbladder is blocked due to the stone, and this obstruction of the cystic duct leads to distension of the gallbladder, ischemia of the gallbladder wall, inflammation and edema, and leading to bacterial infection. Okay, these are the various stages in the development of acute cholecystitis: biliary colic, chemical cholecystitis, septic cholecystitis, empyema of the gallbladder, gangrene, and perforation. Okay, let's see here another chart to show you. The stone here causes two things. Obstruction is the main problem, and secondarily, there's also a mucosal erosion in the gallbladder, which causes destruction by the cells by toxic bile salts. Okay, because the cells are now exposed to toxic bile salts. Obstruction leads to stasis, and this will lead to secondary bacterial infection and necrosis and perforation. Okay, this is a summary of the pathological physiological changes that take place. Stone obstruct the bile flow, distension and ischemia of the gallbladder, mucosa damaged by lysozyme and trauma by the stone, the mucosal irritation, and this leads to chemical cholecystitis. Followed by, if the obstruction is relieved, the stone falls back into the gallbladder, then the whole process reverses and the patient becomes asymptomatic. Otherwise, it proceeds on to form secondary bacterial infection leading to septic cholecystitis. And the sequelae will be, if the stone slips back into the gallbladder, relief of the obstruction takes place and inflammation subsides. And this is known as biliary colic. So biliary colic is a transient obstruction and inflammation, chemical inflammation of the gallbladder. Continuous obstruction leads to secondary infection and empyema of the gallbladder, gangrene and perforation of the gallbladder with localized or diffuse peritonitis. And this stage, the mortality can be high, that's at 50%, especially in patients who are at high risk, diabetic patients, elderly patients, immunocompromised patients. Their mortality can rise as high as 50%. Okay, it is important to know what bacteria secondarily infects the infected or obstructed gallbladder. The bacteria are usually gram-negative aerobes, okay, especially E. coli, Klebsiella, Streptococcus faecalis. There's also, in severe cases, there's also anaerobic bacteria. This includes Bacteroides, Clostridia, which at times causes aerobilia, gas in the biliary tree. And it's very important to understand the causative organism, to appreciate what is your causative organism, so that you can cover the patient effectively with broad spectrum or relevant antibiotics. The most commonly used antibiotics will be cephalosporin with metronidazole. Next, we come to the clinical features. This slide shows you, summarizes the features. First, they have the 4 F's here, or in fact, I've added another one, 5S. Patients are usually fat, fertile, female, 40, age of 40 years old, and with a family history. The patients usually present with colicky pain in the right upper quadrant of the abdomen, and it's more prolonged, nausea and vomiting, and initially low-grade fever. Then fever, this picture here shows you the summarizes fever with leukocytosis. Patient may be jaundice. Usually the jaundice is mild, nausea, vomiting, anorexia, fat intolerance, and pain. Right upper quadrant may radiate to the back and may increase with deep breath. It may also radiate to the right shoulder. Patient also feels a fullness and abdominal distension. So in other clinical features, sudden onset of right hypochondrial pain, nausea, vomiting, and fever, tenderness and guarding over the right hypochondrium, Bohr sign, which is an area of hyperesthesia between the right 9th and 11th ribs posteriorly, and Murphy sign, the sudden holding of breath on inspiration when the right hypochondrium is palpated. Okay. These are the simplified chart, right hypochondrial pain, to show you the symptoms. Right hypochondrial pain, at times it can radiate to the mid-sternal region, mimicking acute myocardial infarction. Pain may radiate to the right shoulder tip, area of hyperesthesia, Bohr sign, over the posterior 9th to 11th ribs at the back, and here again pain over the right shoulder. Okay, this is a slide to show you the Murphy sign, how it is elicited. This is the most common method that we employ. Patient is lying supine, and then the hand, the palm of the hand, tip of the fingers, you cause pressure at the right hypochondrium. And as you apply the pressure, you ask the patient to inspire deeply. Murphy sign is positive when there is a patient stops breathing in inspiration. And this stoppage is due to pain, which is due to an inflamed gallbladder eating the tip of your fingers. Okay, this is another way of doing, using both the arms. Basically, you're applying pressure so that when the patient takes a deep breath, the gallbladder moves down, hits your hand and causes pain. So the patient stops bleeding. This is using your thumb, or any hands modification. Okay, but as far as you are concerned, the most important is to stick to this method of eliciting Murphy sign. There's also a more accurate way of eliciting the Murphy sign by using ultrasound. Okay, this is known as the ultrasonographic Murphy sign, where the probe of the ultrasound is applied onto the distended gallbladder and ask the patient to breathe. Again, if the patient stops in inspiration, then you know it is positive. Next, what's the difference between biliary colic and acute cholecystitis? Here are two things. Basically, biliary colic is a transient obstruction of the neck or gallbladder or the outlet of the gallbladder. And there's no, in early stages, there's no inflammatory response. As a result, usually there's no fever, no tachycardia. Whereas in acute cholecystitis, the pain is more constant. It's due to a more permanent obstruction, infection of the gallbladder outlet by the stone. Pain is in the right hypochondrium or epigastric region, and there is signs of inflammation such as fever, lethargy, and tachycardia. Whereas the pain in biliary colic is usually sudden, dull, and colicky in nature, localized to the right hypochondrium, and may radiate to the epigastrium and the back, similar to cholecystitis. But in this case, the pain and symptoms are usually self-remitting and transient. The pain is precipitated by the consumption of fatty foods and associated with nausea and vomiting in both cases. The Murphy sign may be negative in biliary colic, but is usually positive in acute cholecystitis, and the presence of guarding and rebound tenderness in the right upper quadrant may suggest gallbladder perforation and peritonitis. So in these patients, if there's guarding, you must look for features of sepsis, such as fever with chills and rigors, tachycardia, and patient appeared to be looking very ill. In general, in biliary colic, once the pain relief has started, symptoms usually settle very quickly. So it's a matter of hours, the patient recovers from his symptoms. The classical feature of presentation of biliary colic is a patient who has a heavy meal at night, and hours after he goes to bed, he's suddenly woken up with severe right hypochondrial pain with vomiting and severe nausea. And on treatment, the patient's symptoms subside within a matter of hours. But next morning, he feels much better. The symptoms and signs have subsided, and patient is very ready to go home. Okay, this table again shows you the differences between presenting features between biliary colic and acute cholecystitis. Similarly, initially they all appear same. There's sudden onset of intense right abdominal pain, the right hypochondrium, radiate to the shoulder, associated with sweating, nausea and vomiting. Okay, the features that differentiate is biliary colic from acute cholecystitis is the features of acute inflammation, which is absent in biliary colic. Fever, leukocytosis are traditionally or classically typically absent in biliary colic but present in acute cholecystitis. So is tachycardia, also is a feature of acute cholecystitis, not biliary colic. So acute cholecystitis, the pain is more localized, whereas here it is vague pain in the upper right abdomen, and this is due to visceral pain. And here it is quite localized to the right hypochondrial region. Here it is very vaguely located in the right upper quadrant and epigastric region. Acute cholecystitis lasts longer, more than 3 hours. This is usually within 3 hours the symptoms may reside. Murphy sign is usually positive in acute cholecystitis and usually negative in biliary colic. Fever is present in acute cholecystitis and usually absent in biliary colic. Leukocytosis, is present in acute cholecystitis and absent in biliary colic. So basically, features of acute inflammation is present in acute cholecystitis but typically absent in biliary colic. And this is transient, this is prolonged. Okay, laboratory tests involves blood tests such as the full blood count and creatinine, C-reactive protein, assessment of any inflammatory changes suggestive of acute cholecystitis, liver function test, classically in biliary colic we are negative, and acute cholecystitis also the serum liver enzymes may be normal. ALT and bilirubin should remain within normal limits in acute cholecystitis. A raised alkaline phosphatase may be indicative of some degree of ductal obstruction due to inflammation. Serum amylase or lipase to check for any evidence of pancreatitis. Urine analysis, look for hematuria and leukocyte and white blood cells in the urine, and ECG. Among the imaging methods that are available, first of all, as I said, is a chest X-ray, erect chest X-ray to rule out pneumoperitoneum, which occurs in perforated peptic ulcer. Transabdominal ultrasound is an important and most sensitive first-line investigation, which is very effective in diagnosing gallstones. So in ultrasound, 3 things you must look for: presence of gallstones, gallbladder wall thickening. Normally the gallbladder wall should be less than 3 millimeters. So anything more than that is considered thickened. And bile duct dilatation, which is an indication of possible stone in the distal bile ducts. If ultrasound scans are inconclusive, then you may want to do a MRCP and ERCP, especially so if the patient is jaundice. CT scan may have to be done sometimes if ultrasound is not helpful. So CT scan with MRCP will be able to give you the diagnosis if ultrasound is not helpful. Okay, this is an ultrasound image of a patient with gallstone biliary colic. Okay, see, this is the gallbladder. The wall is thickened. The wall is normal. It is less than 3 millimeters. This is a stone within the lumen. How you know it's a stone? It casts a posterior shadow here. So this is most likely a stone. Okay, this is another ultrasound image, and in this case is acute cholecystitis, where the wall of the gallbladder is inflamed. The inflammatory changes, thickened wall, and also edema known as pericholecystic fluid. So there's a stone here with posterior shadow. So these are features of gallbladder inflammation. So it's acute cholecystitis. This is another picture of a gallbladder, more severe cholecystitis. Okay, the wall is thickened with pericholecystic fluid here. There's biliary sludge and stones. See, you can stones here. Posterior shadow, and posterior shadow. This is a severely inflamed gallbladder, can even be an empyema of the gallbladder. This is a MRCP film showing you multiple filling defects in the gallbladder as well as in the lower end of the bile ducts. The MRCP is very useful for detecting stones in the gallbladder and more so in your bile ducts. Differential diagnosis of acute cholecystitis. The common ones are acute appendicitis, perforated peptic ulcer, and acute pancreatitis. So to rule out acute pancreatitis, you may have to do a serum amylase. Perforated peptic ulcer, normally erect chest X-ray in the majority of cases may reveal air under the right diaphragm. Less common, acute pyelonephritis on the right side, myocardial infarction, and pneumonia involving the right lower lobe. What are the complications of acute cholecystitis? Empyema of the gallbladder, gangrene, perforation of the gallbladder with bile peritonitis, which is a very serious complication, secondary bacterial infection leading to sepsis and septicemia. Recurrent attacks may lead to chronic cholecystitis, Mirazi syndrome, cholecystoduodenal fistula, which can lead to Bowerett syndrome or gallstone IBS. Okay, this is a picture of a gallbladder, empyema of the gallbladder here. The gallbladder is opened up. Okay, a lot of pus within it. Okay, this is before being opened up. If you see the gallbladder is grossly inflamed, the wall is necrotic and thus it filled with pus. Okay, and these patients are usually unwell and septic, and there's significant morbidity and mortality, especially in high-risk patients like elderly patients, immunocompromised patients, and diabetes patients. And it is usually diagnosed with ultrasound, and you may need a CT scan to determine the severity of the inflammation. Okay, this is a gangrenous gallbladder after surgery. So you can see this is a normal color. The gallbladder is darkened. Here there's a gangrene with probably a perforated. You see, you can see the bile leak here. Okay, so this is a perforated gallbladder. These are all CT scans. This is an empyema of the gallbladder. The wall is very irregular and inflamed, and there is this pus collection within the gallbladder. This is a picture of a gangrenous gallbladder, okay, where there is thickened wall and possible necrosis of the gallbladder. There's a stone within it. This is a perforated gallbladder. See, there's a defect in the wall of the gallbladder that is distended, and there's collection of bile around the gallbladder, pericholecystic fluid. Here again, a CT scan showing you is a gallbladder which is gangrenous, and there's a perforation causing collection of fluid and pus within around the gallbladder. So this is a perforated gallbladder. Okay, this is another complication of cholecystitis, more so in chronic cholecystitis rather than acute cholecystitis, where there is inflammation of the gallbladder,
And as the gallbladder, fundus and the body lies very closely related to the first part of the duodenum, inflammation leads to fistula formation. This is the cholecystoduodenal fistula. And the stones from the gallbladder can pass through this fistula and reach the duodenum, first part of the duodenum, where it can cause duodenal obstruction, which is known as Bourret syndrome. Okay, a stone impacts the proximal duodenum, causing gastric outlet obstruction. The patient comes in profuse projectile vomiting. Or more commonly, this stone passes downwards, passes through the small intestine and gets embedded or impacted at the ileocecal junction, which is the narrowest part of the intestine. And that causes blockage there, causes obstruction of the small bowel, and that is known as gallstone ileus. Okay, so Bourret syndrome and gallstone ileus are complications of cholecystitis where cholecystoduodenal fistula is being created. Next is Mirazi syndrome, which the stone in the Hartmann's pouch can cause chronic inflammation, acute and chronic inflammation, and cause pressure on the common hepatic duct. And this pressure on the common hepatic duct causes obstruction and bile stasis in the liver, causing jaundice, obstructive jaundice. Okay, the result is an obstructive jaundice, even without the stones being present in the lumen of the bile ducts. Okay, so obstructive jaundice due to a stone in the cystic duct compressing external pressure on the bile ducts is known as Mirazi syndrome, and is easily diagnosed, as I just showed you the picture, MRCP, and the treatment is laparoscopic cholecystectomy. Okay, now what is the treatment of acute cholecystitis? Initially, conservative treatment followed by cholecystectomy. The basic treatment is conservative initially and then followed by cholecystectomy. The conservative measures are nil by mouth, placement of a nasogastric tube to aspirate the stomach, giving potent analgesics. Many of these patients will need opiate, the IV opiates for effective pain control, broad spectrum antibiotics, which I told you, cephalosporins plus metronidazole, and intravenous fluid to correct the electrolyte imbalance. Okay, as the patient may have not been eating for a few days, and also he may have profuse vomiting, which can lead to fluid and electrolyte imbalance. Once the first stage of the procedure, patient is stabilized, then you can plan for cholecystectomy, which can be done as an emergency or as an elective. Emergency when the patient is not improving within the first 3 days, then you go for emergency cholecystectomy. If the patient improves, then you continue the conservative treatment and plan for an elective cholecystectomy 6 weeks later. Okay, so I emphasize here the treatment is conservative first, followed by elective cholecystectomy. Unless the patient develops complications, then you go for emergency cholecystectomy. And the cholecystectomy, the preferable choice is laparoscopic. As far as possible, we go for laparoscopic cholecystectomy. The other treatments, biliary colic, initial treatment, IV fluids, analgesics, opiates, elective cholecystectomy after 6 weeks. So I told you biliary colic is a transient obstruction and pain, and the patient, but there's a high chance of recurrence leading to complications later if not treated surgically. So in these patients, you go for elective cholecystectomy 6 weeks after the first attack. Acute cholecystitis, initial resuscitation followed by antibiotics, and emergency cholecystectomy or early cholecystectomy if the patient does not improve. If it improves, then elective or delayed cholecystectomy 6 weeks later. For complications of acute cholecystitis, is always emergency or urgent cholecystectomy. For empyema, gangrene, and perforation. First of all, patient is actively resuscitated, potent antibiotics given intravenously, and urgent cholecystectomy done. I put it, the last one here is asymptomatic gallstones. Okay, what to do with patients with asymptomatic gallstones? So these patients generally do not need cholecystectomy, okay, unless they are special risk for complications such as diabetes or patients with concomitant or presence of polyps in the gallbladder with gallstones. Such patients, you need to recommend to do a cholecystectomy. Because in diabetes patients, if they develop acute cholecystitis, the chances of complications are much higher than other patients. The last one is about a word about acalculous cholecystitis. This is sometimes people are very confused as to what is acalculous cholecystitis. Acalculous cholecystitis, as the name suggests, is cholecystitis that occurs without a gallstone. I told you, almost always acute cholecystitis is caused by gallstones. But in less than 10% of patients, it occurs without the presence of a gallstone. This typically occurs in critically ill patients who are ventilated in ICU with other medical problems. Okay, and this is basically the cholecystitis is a complication of these other critically ill patients to a combination of factors like bile stasis, hypoperfusion, general hypoperfusion, including ischemia of the gallbladder, and that can lead to acute cholecystitis. Acalculous cholecystitis often goes unrecognized initially because of the patient's medical illness. It is associated with high mortality and due to septicemia and the comorbid medical conditions that are existing. Treatment is emergency cholecystectomy, but the prognosis is poor, okay, because of the poor general condition of the patient. Okay, this is an image. This is an ultrasound image of a patient with marked gallbladder thickening here. Okay, and there's hypogenic echoes here in the wall of the gallbladder, but there's no gallstone seen within the gallbladder. This is acute acalculous cholecystitis. Okay, with possibly gas in the wall of the gallbladder known as emphysematous cholecystitis. This is a CT scan of the patient showing you this is the gallbladder with this leakage. Okay, this is there's no gallstone within the listing. There is massive inflammation of the gallbladder, and this is your acute acalculous cholecystitis. In summary, these are some important facts about acute cholecystitis. Acute cholecystitis is acute inflammation of the gallbladder that develops over hours. It is an acute onset, almost always because of a gallstone causing obstruction of the cystic duct. The symptoms include upper quadrant pain, right upper quadrant pain, and tenderness. Sometimes, if it is infected, secondarily bacterial infection leads to fever, chills, nausea, and vomiting. Diagnosis is mainly by ultrasound scan, which is an effective tool in the diagnosis of acute cholecystitis. Clinical features with the presence of stones on ultrasound are more or less definitive diagnosis of acute cholecystitis. Treatment is conservative initially with antibiotics and analgesics, followed by laparoscopic cholecystectomy, which is done either as emergency or as an elective procedure after 6 weeks.